Everyone, welcome to this ASCO GU virtual roundtable. My name is Brian Rini, and I'm a professor of medicine at Vanderbilt and Vanderbilt Ingram Cancer Center. And I appreciate being joined today by several experts in the field, and I'm going to have them introduce themselves, and we will start with Dr. Plimack.
Hi, I'm Betsy Plimack. I'm a GU medical oncologist at Fox Chase Cancer Center in Philadelphia.
And Dr. McDermott.
David McDermott. I'm a medical oncologist here in Boston at Beth Israel Deaconess Medical Center.
Thank you. And Dr. Voss.
Yeah, hi, Martin Voss. I'm a geomedical oncologist also, and I practice at Memorial Sloan Kettering Cancer Center in New York.
Great. I appreciate you all joining us, and you all have extensive expertise in kidney cancer and drug development, so it should be a fun discussion. We're going to touch on several areas in the landscape of kidney cancer, incorporating some of the data that was presented just recently at ASCO GU in San Francisco. And we'll start with frontline clear cell kidney cancer. We'll talk then about non-clear cell. We'll cover some of the other major updates, including the adjuvant setting, and then probably end with, sort of what you're most excited about, as we head into the future and to the main ASCO meeting. Let's move on to non-clear cell. So Martin, we'll start back with you. B61 was a trial of len/pembro across non-clear cell histologies. I think the largest non-clear cell trial ever done, maybe, or certainly it's up there. Do you want to just, sort of maybe summarize those data briefly, and then we can sort of talk about our individual approaches?
Yeah, of course. So this is a study that's previously been analyzed and actually reported in print already. So it's fully accrued and analyzed. The first, planned analysis was presented previously and published in Lancet Oncology in 2023. Laurence Albigès was the first author on the publication. And this is a 158 patient strong study, single arm, multiple institutions conducted across 14 countries, and enrolled patients to be treated with standard lenvatinib pembrolizumab at the dosing schedule that we're all used to until disease progression or intolerance, with a max of 2 years pembrolizumab, as we're all used to doing in clear cell RCC. Primary endpoint for the study was objective response, and this was enrolling patients with untreated non-clear cell variants. For the most part, those were papillary kidney cancer patients, about 90 patients with papillary, 30 chromophobe patients, which is the largest chromophobe group reported prospectively, unclassified patients, and a small group of translocation patients. I think it was 6. And in the original publication, response was assessed, reported, as well as secondary endpoints and tolerance. And it showed a robust signal across disease groups, maybe more so in some than in others. Again, the chromophobes stood out as the ones that seemed to benefit least from an IO-containing combination, but the papillaries and the unclassifieds had a high response, and we confirmed this in this analysis. So the original analysis had 15 months median follow-up, and this one had 6 months extra, so about 23 months median follow-up, which was helpful in some ways and just reaffirmed the rest. For instance, there was no median duration of response yet reported in the original publication. Now with more follow-up, we can see that median duration of response just short of 20 months, which I think is clinically meaningful, and the level of efficacy is robust, specifically in papillary, where it's about a 50% response rate, including CRs. Similarly, there are responses, and there was also a CR in translocation patients. No CR in the chromophobe group. Response rates have gone up in all the groups a little bit with more follow-up, as you would expect, and the chromophobes are somewhere in the low 30s, which we can then argue, is that the lenvatinib alone, or is it lenvatinib for most patients, and maybe less IO effect, but the sort of this additive effect that we see across all kidney cancer variants, as we had seen in clear cell, maybe a little bit less clear there. But I do think, and with that I'll shut up, it is the biggest data set that's out there now, and I do think it sends a very clear message, and it did show across all groups a very low PD rate also. So similar to what we've discussed before, I think this is a regimen that I think should be considered for most patients with non-clear cell variants anyway.
Yeah. So Betsy, you're shaking your head, and you said you're a len/pembro user for clear cell. So I assume, is that your approach in non-clear cell based on these data, or what are the nuances to that?
That did become my approach when I first saw these presented back at ESMO. Just because it's such a large series, I really hone in on papillary, because I think the numbers are just very small in the other cancers that I see regularly, mostly chromophobe. But to get that CR rate, it's about a 10% CR in papillary. I have to hypothesize that the IO is doing something or is somewhat responsible for that. David had data on pembro alone in papillary, and there was activity. So I think it just makes logical sense to link the two. I think the data support that. The large numbers support that. And just anecdotally, in my experience, it's gone really well in clinic. So it's maybe some soft reasons atop hard data that this is really the standard of care for me in papillary.
Right. And David, as Betsy alluded to, KEYNOTE-427, I think it was cohort B, was pembro monotherapy and sort of a similar, heterogeneous non-clear cell cohort. I think the good news is in this field, we're starting to get actual large studies in these diseases and not just, case series and such. So they're not yet large randomized trials, but they're, narrower confidence intervals so we can actually assess the activity. So David, what do you think of these data, and what's your approach to, let's just use papillary as the most common example. What's your approach to the metastatic papillary patient?
Well, I agree with my colleagues that len-pembro data is impressive. I've tended to use for papillary more nivo-cabo, but that's more just experience and what we have done, and maybe it's the cabo targeting MET story, which hasn't been fully fleshed out, but maybe there's something there. But I think len-pembro is just as good. Totally reasonable in that setting. I think to your point, though, we can accrue these patients to trials now. So we should be doing more of them and potentially exploring new mechanisms of action, because we could actually execute those trials. I think those patients certainly need that trials, and also comparing data sets. So comparing the data that Martin collected with the 427 data would be good, not just from a clinical standpoint, as Betsy mentioned, but from a molecular standpoint. I mean, what are the signatures of the responders in those patients? That's information that's knowable, and we should try to explore it with our industry colleagues, I think.
So you tend to give nivo-cabo, len-pembro is reasonable. Are you giving anybody ipi-nivo, any non-clear cell?
Not generally. The data there is okay, but there's no evidence that, obviously cross-trial, that ipi is adding much in those patients. So I generally stay away from it.
Okay. But non-clear cell with sarcomatoid, you might give ipi-nivo?
Yes.
Or? Okay.
Absolutely.
Does everybody kind of agree with that?
Well, I would say that there's just no data, for it, but the signal is so strong in clear cell that I don't think it's unreasonable. And the 920 study did show efficacy, but regardless of sarcomatoid or not. I think it's the type scenario where the patient may weigh in also. Sometimes I have like a young patient who really wants CTLA-4 inhibition because they've done their research and they feel very strongly about it. And I think then it's our job to help them understand the limitations of the data that is there. They have non-clear cell, there just isn't that strong data. They need to know what the pros and cons are, what the risks are, and then I would not keep that patient, from the therapy. We've had it our conversation. I get the sense that they understood what I tried to tell them. I think one other practical consideration that I think is important, especially for those of us who are at centers that have non-clear cell trials, sometimes, it is important to also think through, sequencing long terms. And with the median duration of response, of under 2 years, I think it is important to keep in mind, what is going to happen afterwards and what's available. And sometimes I might, favor one regimen over another because in the second line, I already have sort of something in mind, or I have a strategy that's emerging as a clinical trial opportunity for this patient that they otherwise might not have, right? So if I had a cabo-based second line combination trial that I think is promising for that particular entity, I might be, reassured to give them len-pem in the first line, because then if it did fail in the first year or so, I might have a good option for them to sequence onto. Because I do not think that based on the data we have, len-pem is definitely stronger than cabo-nivo. It's a more robust data set, it's more patients, but I think that the two trials tell the same story: high response rate in papillary, low PD rate, and so forth.
Mm-hmm. Agreed. For the group, is there any patient, barring sort of absolute contraindications, that you're giving upfront single agent TKI, any non-clear cell patient, you're giving like just cabo monotherapy to any patient, or I guess immune monotherapy, barring again the obvious solid organ transplant, or barring something where you just can't give the immune drug? Is there any patient phenotypes where you're just giving one drug?
I would say chromophobe. I'm really not convinced the IO is adding much. It tends to be a very cold tumor. I do sequence it, and if there's any PD-L1 signal, then I would, give an IO containing regimen. But those tumors tend to grow really slowly and shrink really slowly, and you're in it for the long game. And so, I think it's reasonable to do TKI alone there. I've done it.
So you do TKI monotherapy, and you choose Cabo, or?
I choose Cabo.
Okay. And then if they're PD-L1, if they progress and are PD-L1 positive, then you might consider immune therapy.
If they're PD-L1 positive, I would do it up front. I would include it up front.
Okay.
Yeah. If they're PD-L1 negative, I would start with Cabo typically. And then Len-Ev actually had some very small series data in chromophobe that I thought was interesting. So I've sequenced that in as well.
And so Len-Ev, just maybe for the audience, is there was a grand total of 9 patients with chromophobe treated with Len-Ev, 4 of whom responded. So it's the most quoted 9-patient subset in the history of oncology. It certainly has activity, right? We've all used it and it has activity, although I very much believe the 35% response rate from Len-Pembro, which I believe it wasn't chromophobe, versus that 44% where the confidence intervals are probably 0 to 100. But where do people use Len-Ev and chromophobe? Maybe Martin, will start with you.
So I do use it. I do think that through the years it's clearly been come up again and again that mTOR inhibition has merit in this particular entity. I think it's reasonable to use Len-Ev upfront in someone who's symptomatic from their disease or who needs a response. It's just notably more toxic than given TKI monotherapy or TKI IO. And that's based on personal experience, which I think is okay given how little data is out there. I sometimes favor everolimus bevacizumab over lenvatinib everolimus. We did a phase 2 study at our institution that included some chromophobe patient, and I had 2 patients that were on that regimen with me for years. They came off the Avastin at some point because of proteinuria, but they stayed then on the everolimus. And it's much easier in my experience to give them a TKI-based combo. But it's, the strategy is the same to me. So, we know it's effective with all the limitations of the data. I think it's reasonable to give knowing the tox, keeping that in mind.
And I think, as you can tell, when you get down to these super rare subsets, we all probably do something different, and none of them are wrong or right, frankly, because they're sort of almost anecdotal based. But I think we all agree we need better insight into the biology of non-clear cell in general, and certainly chromophobe. But sounds like a relative consensus for IO TKI in this patient population, with the sort of the caveats and nuances that we mentioned.